This program is brought to you by Emory University.
Good morning, everyone. Thanks for being here on this Friday morning for our second Fellows Conference of the year. As you can see on your screen, our speaker this morning is Spencer Maddox. Spencer is one of our third-year clinical fellows, and he is a native of Johns Creek, Georgia, and will be did his residency here at Emory, including a chief resident year, and will be heading to Northwest Georgia to join the Harbin Clinic next year, and has been doing some extra training in cardiac MRI, which is what he's going to talk to us about today. So looking forward to hearing from him. Spencer Maddox.
Thanks, Dr. Williams. All right, so we will get started with this. So I think, this talk, we're going to talk kind of about what what clinical questions can be answered with cardiac MRI. I'm not going to be spending a ton of time on physics and things like that. I think, that's not, that loses people as far as interest goes. And I think, for our general fellows, it's more applicable kind of figure out, when I'm ordering an MRI, what kind of things can I look for? What kind of questions can I answer? So I don't have any disclosures as far as learning objectives for this. So we're just going to talk about briefly the basic sequences that we can obtain from a cardiac MRI and what the usual protocol is that we do. See if CMR is basically the appropriate question, the appropriate modality to answer the question that you have, your clinical question, and then look at certain patterns on CMR to figure out for different pathologies, common patterns that we see and common things that we see with different disease processes. So when patients come down there, as far as setting up their images, we basically have to kind of it's a orthogonal kind of 3 planes that we use to center the heart and figure out exactly where the heart is when the patient gets down the table. And then we set up these axial, coronal and sagittal sections through the heart and then kind of proceed from that standpoint. Once we get everything centered up and are able to kind of view things in multiple different planes, we have the patient go through a series of image acquisitions, which include breath holds and things like that to minimize movement, respiratory motion, and get kind of isolated pictures of the heart and answer the question that we're trying to answer. So the basic images, the things that we kind of get the most of and that are honestly, when you start looking at these, that are most similar to what we're used to looking at with echo, are these CINA or SSFP images. So these are, like I said, these are most similar to echo. We get a 2-chamber image where you're looking for wall motion, EF, and looking for any evidence of MR. 3-chamber images where you're looking, basically, you're similar to echo, you're measuring your LV volumes and sizes and wall thickness, as well as looking at those other things such as wall motion, EF, and MR. A 4-chamber view where you get to see your RV, that kind of horizontal long axis view. We also get our atrial areas and volumes from this view and look at TR. A short axis view, similar to what we use short axis for on echo, where you use it basically to look for wall motion and EF, and we'll talk about the calculations that you can get as far as EF from the short axis views. An LVOT measurement, which is what this image here is basically showing you kind of our LVOT CINA images, and so there we can get aortic measurements. You can measure root and the sinuses and at the STJ, as well as the ascending aorta on this view, and look at basically AI, kind of get an idea about the morphology of any AI that you may have. This is an RVOT view, so you can look at the pulmonic valve structure. Here's the pulmonic valve here, and here's the RVOT and the main PA coming out, and look for any PI here as well. And then have an RV inflow view where you also can look at the structure of the pulmonic valve, look for any TR, and look at your tricuspid valve structure. So these images, when you acquire them, basically these play like an echo image on loop. So when the patient is on the table, we're using ECG gating to kind of acquire the images. So basically what happens is they take a breath, and then the ECG that's on the patient, the MRI scanner looks for diastole, and then that will kind of get your still images there, and then basically takes images throughout the cardiac cycle at different points throughout the entire cardiac cycle based on the ECG when the patient's holding their breath. Then we have them stop holding their breath, and we kind of do series of image acquisitions in this way. And so patients, depending on how slow or fast their heart rate is, depends on how long they'll need to hold their breath for, and depends on kind of what image acquisition you're trying to get for how long the breath holds have to be. You have to keep that in mind when you're imaging patients. They may be in congestive heart failure or have underlying lung disease. If you're looking for sarcoid and you've got a patient, on a ton of oxygen, they may not be able to do adequate breath holds. So you have to kind of keep that in mind when you're taking your images and figuring out your protocol beforehand to figure out what kind of images you're able to get. Another thing that we do then after we kind of get our thin A images and basically go through all the different planes that we want and views that we want to see the heart in, is we get flow measurements. So this is phase contrast MRI, and so that you kind of get a through plane flow measurement, which I'll show you in just a second, which has a variety of clinical applications, really helpful for us. So you can get the flow through whatever section and whatever slice that you're getting, and I'll show you how to do that. And basically that gives you the exact milliliter flow through that section. It also will give you the peak velocity through that slice as well. For image acquisition, you're calculating, you're having basically using the bank time, which is I'll show you the aliasing that comes with that, and you use that to show basically your velocity through there. You're looking for the lowest bank time that will capture the peak velocity through whatever slice you're cutting. And so you basically, if you have increasing bank time, that shows you that they may have a stenosis there or increased velocity through that slice. Things that we calculate typically are the aortic flow. So we take a slice right after the tips of the aortic valve in the aorta, and so you can get the exact flow as in milliliters out of the aorta. We also get the pulmonic flow, including the right pulmonary artery and left pulmonary artery flows. So this has a lot of congenital heart disease applications. Certainly, if you're looking for different types of shunts, and you're looking for if patients have certain stenoses in branch pulmonary arteries, or you'd expect different flow patterns between your RV and your LV. This can kind of help you figure out those differences. So how we do this is that you get this image here, which is kind of just a regular magnitude image there. And so this arrow points to the main pulmonary artery. And then the phase contrast mapping, you can kind of see here, you use this as reference, and you can see exactly where your flow is. And so during systole, flow will be white coming towards you, and then during diastole, it'll be dark if it's going away from you. And so we draw a contour around this, and then we map that through each phase of the cardiac cycle, the entire cardiac cycle. And then you basically use that to calculate, and it will tell you the flow through this slice, and it gives you that in kind of a graphical form. So you can see, at the beginning of systole, your flow will obviously increase and then peak out, and then we'll go back down at the end of systole. And then you can see during diastole, if there's significant valvular regurgitation, it'll show up dark here, and it'll measure the exact amount of valvular regurgitation in milliliters. So you can then use that. We'll talk about a little bit later about some calculations that you can use that in. And then this will work. We do this here in the main PA, and then we'll use a different slice and get through the aorta to get different flows kind of between those two areas. You can use this to calculate. And this is kind of what through plane. So we're cutting a cross section through the PA right here to measure the flow. We're perpendicular to flow, so we're able to measure it. You can also do in plane measurements where you're parallel to flow. And this will show you it won't quantify it, but it will show you areas of potential flow acceleration, which is helpful in patients with hypertrophic cardiomyopathy or AS. If you're looking for if there's a gradient, intracavitary gradient or LVOT gradient in hypertrophic cardiomyopathy cases, it'll tell you kind of where that flow acceleration is. And similarly with AS, it'll show you where the flow acceleration is, and might give you an idea of where your exact stenosis is if you're looking for like subvalvular stenosis or supravalvular stenosis in AS. You can also calculate a QP to QS ratio with this, so you'll get an exact PA flow and an exact LV flow, aortic flow, and so those should be very similar if you don't have any shunt or any significant valvular regurgitant lesions or something like that. And so it's helpful in those cases if you're looking for shunt to be able to calculate a QP QS off of this. AI, PI, MR, and TR we'll talk about a little bit later. But you can use, this is how we calculate the regurgitant fraction for each of those lesions, is using this flow measurements. And then it's also kind of a helpful self-check for when you calculate your left ventricular and right ventricular stroke volume, which I'll show you how to do on the short axis slices a little bit later. And so when you're looking at your short axis cine images, you can actually calculate exact LV and RV stroke volume. And so without any significant regurgitation, you should have a similar stroke volume for the LV and RV as your aortic and pulmonic flows. So it's helpful. The flows, are pretty accurate and difficult to mess up. And so that number, if your stroke volume is significantly off from that, then you know that your contours that you've drawn on your stroke volume measurements are probably a little bit off. We also then do T1 mapping. So T1 is basically the longitudinal reaction time. It's also called spin lattice after a radio frequency pulse is delivered to the heart. And so it's the relaxation time basically after the heart's been after that pulse has been delivered, and then to kind of reorient in the magnet. It's an intrinsic property of the tissue, so it's a time measurement. So certain pathologies can basically measure or shorten the T1 time. There's a normal value for T1 time, and so if you have a longer or higher T1 time, that's indicative of potentially increased extracellular volume, or like basically we call that, you're looking for fibrosis with a higher T1 time. There is some things that cause a shorter T1 time, so fat specifically, like in Fabry's disease, or iron, like in hemochromatosis. Both of those can cause a shorter T1 time. That's another thing that you can check for with your T1 mapping, which I'll show you in just a second. So basically how it's done is there are the images are in a two-dimensional plane. We do certain slices through certain areas on every patient. We kind of do like a short axis, a long axis, a 2-chamber and a 4-chamber to show the respective T1 times. They're shown on our software as a color spectrum, where samples are taken kind of at different areas, and so higher T1 times will be represented by a different color versus lower. And so you can kind of see the overall map, and then you take samples at each at areas of interest that will tell you what the T1 time is in that area. So this is kind of what it looks like, the T1 mapping. And so over here on the right, you see a normal, a normal myocardium. This is kind of short axis, and then a 4-chamber view. And so you see that it's nice, homogeneous throughout the entire myocardium, and that your TI time is kind of closer to that. Really, anything above 1200, it starts to become abnormal. So it's probably, around 1,000, 1,100 for this that you would see. And so you can go through and sample this at different portions and kind of see that you have a normal T1 time, which is what you see visually as well. So something like amyloid has a lot of fibrosis and extracellular volume. And so you'd expect your T1 time to be abnormal. And so you see here how it's much brighter kind of diffusely throughout. So if you went through and sampled this, you'd see that you have a really high T1 time. So this is helpful in cardiac amyloid. We'll talk about it in other diseases as well. And then something that lowers your T1 time, basically something that's like this is infarct here. So you expect this is like there's nulling there, but that you can also have kind of a lower T1 time for things like iron deposition specifically is kind of the big one that we look for that you would see abnormal in the T1 mapping. T2 mapping. So this is the transverse relaxation time. It's just something else that you can measure after that radio frequency pulse is delivered. So the T2 time is lengthened by something that increases your extracellular volume water content. So we think about this as basically edema. So T1 is looking for fibrosis, and T2 you're looking for edema. So the edema can be present in a lot of different things, specifically acute MI, myocarditis, sarcoid, transplant patients that have rejection would be expected to have abnormal T2 times. We certainly kind of look for it most in myocarditis as the one that is kind of the hallmark for the T2 time to be abnormal. And so this graphic here at the bottom shows several different diseases, looking mostly at the T1s, looking at, you can also measure extracellular volume, which I'm not going to get into, but that's something you can use based off of your T1 images post contrast. You can use to kind of calculate what the actual extracellular volume is if you specifically have concern for something like amyloidosis. And then your T2 times here. And so you look here at these T2 images, for instance, in the myocarditis patient, it's much brighter here, which kind of helps point towards there being a lot of edema in that myocardium compared to this normal myocardium here, looks homogeneous throughout. Similarly, iron overload will be kind of the opposite in the T2 times as well. That's really, I think, it for this slide. One of the main functions of cardiac MR is for accurate assessment of the LV and RV function, and also ventricular volumes, both at end-systole and end-diastole. I'll show you how we do that in just a second. And so this is something that people use a lot of times if you're having, varying EFs on echo that you can't, or you're having really poor windows, you're not able to kind of figure out what the exact function is, or specifically if you're looking for in valvular patients or congenital patients, what the exact volumes are, the LV and RV volumes at end systole and end diastole. MRI is an excellent way to do that. And so that's kind of what we use these Cine short axis images for. So there are some potential pitfalls. Basically what you're doing, and I'll show you, this is what you end up doing, is you're tracing contours. We call it downstairs, doing your circle time, where you go through each slice and you trace the contour of the LV endocardium and LV epicardium here. And then the same thing for the RV. And so LV is something that is relatively straightforward. It's a pretty circular throughout the cardiac cycle. But as you can see on these images, the RV anatomically, it certainly can be a little bit difficult to figure out exactly where RV is and trace it to be exactly what the contour should be, and make sure you're including all of it, but not RVOT, not atria. So it's a little bit more difficult with the RVOT, or sorry, the RV measurements than it is with the LV. And so with this, we take these, if we go through the entire heart from base to apex at end diastole and draw those contours, and then go through the entire heart from base to apex and end systole, and then use those volumes to calculate your EF for LV and RV. So the pitfalls basically are that once you get towards the base and apex, you really have to be careful to make sure that you're measuring things that are truly in the heart and truly endocardium, and that you're getting the right measurements, because one extra slice on either side, particularly at the base, can make drastic changes to what your LVEF is and what your volumes end up being. If you include something that is not LV or at the base at end diastole or end systole, that can drastically affect what the total volume is, and thus affect what your EF is. So it's important to compare the stroke volumes with the quantitative flow data that we talked about earlier from the aortic and the PA flow, to make sure that unless outside of significant regurgitation, that you have similar values for your flow data and for your stroke volumes. We get all the values, EDV, ESV, stroke volume, as well as indexed measurements with BSA from these images. And so this is really a big part of what we do and what a lot of people are looking for when they order a CMR. Next, we'll talk about tagging, which honestly is a little bit complex. I probably cannot explain it in its full depth, but this is the cardiac MRI version of myocardial strain. So the myocardium we basically is tagged with these radio frequency tagging with an overlying grid, and I'll show you that in a second on these cine images. And what you're doing with this is you're looking for regional wall motion abnormality, and specifically also looking for constrictive pericarditis. So these are kind of the two questions that you get with tagging. We don't necessarily do this on every patient. If you're looking specifically for constriction, we'll do it. Other times we don't, because it's kind of difficult to interpret. So this is what the tagging images look like. And so you'll see that there's this grid that gets overlaid over the myocardium, and this is done in diastole here, and this is in systole. And so you see the distortion of this grid, which is nice and square here in diastole, and then here in systole, you kind of see how these squares are then distorted. And so the idea would be that if you have regional wall motion abnormality, you'll be able to kind of easily pick out which section of your myocardium doesn't look similar and doesn't look like it's being pulled in systole. And so you're looking for that distortion there. And again, you could see how this would be subtle and honestly difficult sometimes to kind of interpret exactly where you're seeing that at. Similar, this is just a 4-chamber view kind of looking at the same thing. This is more often what we use it for, more so than the regional wall motion abnormality is in constrictive pericarditis. And so here, the LV is tagged, and you see the grid here, and then this is actually the pericardium around it that you can see. And so when in the cardiac cycle you play these images and the heart's beating, what you should see is that these two kind of slide nicely next to each other, and you not see a lot of distortion. But like, for instance, right here, you can see that these squares are kind of distorted, which tells you that as the heart is beating, it's pulling this pericardium in. And so there's probably some adherence there between the pericardium and the myocardium there. And so we use this in looking in similar, you can see here the distortion right here at this border. So this is kind of helpful, and certainly other things that you can do. You're looking for ventricular interdependence, and you do some free breathing images for constrictive pericarditis as well that you can do to look at. It's not the only thing we use, but this is helpful to kind of see where the pericardium might be adherent to the myocardium. We do perfusion images as well. So these, oftentimes these are pretty much every time our protocol is to use gadolinium contrast on these patients. You can do stress testing with MRI. So we'll do adenosine stress testing or dobutamine stress testing on these patients. And so you get these kind of rest perfusion images, and then you get stress perfusion images with the gadolinium contrast administration when the patient's at stress. And so you can see here the gadolinium has been taken up by the rest of the myocardium. It looks kind of similar to the blood pool here, and then in this area right here and like here, you see that there's a lack of uptake there at the stress images. And so this is kind of your first pass images. So the contrast is injected, you'll see it go in, and then it'll basically within a few beats you'll see it kind of have taken up here in the myocardium as it goes into all the capillaries in the myocardium there. And then here where there's ischemia in that area, you'll see that it's not taken up. And so this is how like an abnormal stress MRI would look. Also, you get cine images at the same time, so you can see regional wall motion abnormality, and then we'll talk about the late gadolinium enhancement in just a second. So we do get kind of these initial perfusion images a lot of times. We get these initial perfusion images on every patient looking for resting perfusion defects. And then if patients have, if you're specifically doing a stress test on patients doing a stress MRI, that's what we look for here. So the big part of MRI is late gadolinium enhancement. That is what a lot of times what people are looking for, and kind of the key finding that we do for these studies. So after gadolinium contrast is administered, we acquire images like 10 to 20 minutes later to assess for late gadolinium enhancement. After we basically give the gadolinium time to be taken up kind of throughout the myocardium and then disperse out of the blood pool, and then you look at these images and looking for areas where fibrosis has been potentially. And so we apply then an inversion pulse, which nulls the myocardium. So you'll see here how the rest of the myocardium is very dark. there, depending on the time that we use, the TI time, the inversion time is what it's called. You set that, you go through the images and figure out what image the myocardium looks most nulled at and completely blacked out is what you're looking for. And then your gadolinium enhancement will be bright on these images. And so what we're looking for is our bright areas. The reason that this lights up and what you're basically showing there is that there's the regional differences in the extracellular volume and different uptake and washout patterns in the extracellular space that occur in abnormal myocardium compared to normal myocardium. So this is representative of lots of different things. It's anything that will kind of disrupt the extracellular volume and the cells themselves, representative of myocardial injury. So necrosis, edema, myocardial scar tissue, and fibrosis all are going to show up on your late gadolinium images as enhancement. It's helpful in pretty much every case that we do, but most specifically the times that we're looking for it are in MI, myocarditis, cardiac sarcoid, cardiac amyloid, and hypertrophic cardiomyopathy. CMR is included. Now we're going to kind of talk about different disease processes. So these are basically all the images that we've gone through. These are the standard protocol that we do, is obtaining all these different sets of images, looking at things as far as the guidelines go and where cardiac MRI is specifically recommended. So this kind of shows, but there's a lot of things where you can talk about basically CMR, echo, or CT. It's helpful for these imaging modalities for different disease processes, which we'll kind of talk about here in a second on the rest of this. So looking first at coronary disease, the thing that we use MR for most is for viability in these patients. Remember that this is a measure, what we're looking at for is viability, not that viability and contractility are two different things. A myocardium can have abnormal wall motion, abnormal contractility, and still be viable. That gets to the idea of stunned versus hibernating myocardium. So stunned myocardium is myocardium that initially was ischemic and then has been reperfused and may still have impaired contractility, but the actual myocardium itself is viable and functional. It may not be contractile at this point, and the idea would be that stunned myocardium would improve, and that your contractility would improve with time, versus hibernating myocardium, which is chronically ischemic myocardium. So its abnormal wall motion is based on continued ischemia, as opposed to this hibernating myocardium, which has been reperfused. CMR can also detect no reflow, so on cases where there's a lot of thrombus burden or downstream occlusion after PCI, the MR can also be helpful. You can get a cardiac MRI and kind of show which areas have that no reflow downstream, where you have the subendocardial injury in the distal vessel there. And so you may have reopened your vessel. You get an MRI on that patient, you have a lot of, and we can show kind of this no reflow where you have poor perfusion downstream, and subendocardial tissue is still ischemic, which has a worsened prognosis in MI compared to cases without that. So what we'd expect to see on gadolinium, LGE on these patients, depending on kind of your ischemic time in patients with MI. If you don't have any infarct, we expect to see no gadolinium enhancement when these patients come down, as opposed to, and then basically with increasing ischemic time, you have increasing time of infarct. Once you get past 3 to 6 hours, typically we expect this to be non-viable myocardium with a transmural infarct, on gadolinium enhancement images. This again goes back to the stunned myocardium versus hibernating myocardium versus different types of MI. And so, here you would see that in non-transmural MI, you'd expect your function to be relatively normal. And then in transmural MI, you'd have reduced, and then your function would also be reduced in all of these things: transmural MI, stunned myocardium, more hibernating myocardium. But specifically, when you get down to the perfusion, you would see that this would be, depending on where you're at in the spectrum of your MI, whether it's been reperfused or not, whether you have microvascular obstruction or not, that no reflow, you'd expect your perfusion to be different on the transmural MI versus your stunned myocardium should be normal perfusion, and your hibernating myocardium, by definition, because it's chronically ischemic, would be considered to have a abnormal perfusion. This is talking about FDG update, but it honestly applies to LG, to gadolinium as well, what we'd expect to see for these patients. So if you're doing a viability protocol, these are the steps that we take. Typically, you basically get your normal images, inject your gadolinium, wait about 10 minutes, and then obtain your LGE minutes. So you can really do a viability protocol if you're looking just for viability, really in a pretty short amount of time. In a patient with an infarct or an acute MI, you would expect your T1 and T2s to be abnormal. Your T1, if a patient has had an infarct and that area has been replaced by fibrosis, you'd expect there to be extracellular volume abnormalities there and your T1 mapping to be abnormal. In the more acute phase, you'd expect your T2 to be abnormal given the edema associated with an acute MI. So you get the T1, T2 images we just talked about. You're looking at your cine images, looking for wall motion abnormality, and then your delayed gadolinium enhancement is kind of the gold standard for looking at viability by MR. This goes back to that same image we talked about. So when we're looking at these delayed images, we're trying to figure out what percentage of the myocardium has delayed enhancement. And so we say that the 50%, if your delayed enhancement is 50% or less in that particular segment, we use a 17 segment model like we do in nuclear and everything else. If you have 50% 50% involvement of your gadolinium enhancement or less, that's considered viable myocardium. Above 50% is non-viable myocardium. And so myocardium that is non-viable by MRI, you would not expect to see improvement in function after revascularization. If you're talking about CABG or multivessel PCI in somebody that has severe coronary disease, and then you get an MRI on them looking for viability, if you see more than 50% enhancement in that section, you would not expect that function to improve if you revascularize that territory. This is telling you for each of these, how much enhancement you see in that area, how much what the expected percentage roughly that you would expect to see improvement in. And so in a patient without any late gadolinium enhancement, if you reperfuse that territory, if there was, you had abnormal perfusion in that territory, you would expect 80% of the time to see improvement in function. So this goes up as you get up to greater than 75%, less than 1% chance of improvement in function. Once you get to 50 to 25, this is kind of that cutoff that we use. You really only 10% of the time would expect to see improvement in function with revascularization. So these images, this shows you, so this is normal myocardium here. You see the nice null myocardium, and then just this tiny portion here in the inferior wall that has a little bit of gadolinium enhancement that we call in that 1 to 25%. Here you would call about 50% over in this infraseptal region. And then once you start to get up here, this you would say that most of the wall is involved in this infarct, and then that would not be viable territory. And here it can be a little bit difficult if somebody has a true, like an old MI. As you can tell, it's a really nice hinge point right here for where the myocardium is nice and thick and nulled here, and then you see this thinning out. And then it's almost difficult to say how much enhancement you have because it's so thinned out. There's just not a lot of myocardium there, but you can tell that whatever it is there, it lights up and we would say is non-viable in a transmural infarct. If someone has low EF, we would like to see at least 10 or more viable segments of the 17 segments. So you go through and look, we go through and grade each segment for viability, and you would really want to see more than 10 segments to be viable if you want to have a dramatic improvement or a significant improvement in function with revascularization. We'd expect to see at least 10 segments or more be viable. This slide, I think time-wise probably we'll skip, but this goes through and just kind of talks about different ways, depending on what type of MI you have, how MRI might be helpful in that clinical setting. And so even in patients with that you go and they have basically an ST segment elevation. These are all patients with ST segment elevations. You cath them, and then you see whether you have a culprit lesion or not, or you have multiple culprit lesions. And so how MRI could help you kind of differentiate, the patients that don't have coronary disease, that have a positive troponin, things like myocarditis, Takotsubo, embolism, all those things would have certain findings that we would look for on MRI that could kind of help differentiate what caused the patient's presentation. So I'm going to talk about all the different cardiomyopathies that you can evaluate with CMR. The first is just kind of your dilated, your non-ischemic cardiomyopathies. And so people will send us patients that are have low EF and have negative, don't have coronary disease, and they're kind of looking for etiology of heart failure. So most patients, the vast majority of patients with non-ischemic cardiomyopathy typically have normal gadolinium images. Patients with dilated cardiomyopathy, about 25% will kind of have this non-specific, what we call this mid-wall LGE. So you'll see here this kind of brightened section here in the middle of the myocardium. This is non-specific, but we just call, basically a non-ischemic cardiomyopathy type pattern if you see this mid-wall. And what this is thought to be is probably likely old healed myocarditis that the patient had previously, showing the scar from that probably is what the mid-wall LGE represents. If you have a patient with non-ischemic cardiomyopathy, if they have late gadolinium enhancement or abnormal T1 mapping, that's kind of associated with significantly worsened outcomes, worsened heart failure, increasing amounts of ICD shocks, et cetera, just an overall worsened prognosis from a heart failure standpoint, if you do have a non-ischemic patient with an abnormal gadolinium enhancement. Myocarditis, so after you have this kind of initial insult from myocarditis, you get a lot of inflammation, edema, myocyte injury in that area, and infiltration in that area. And so that's what you'll see on MRI as well. Eventually, you get infiltration and eventually, if it's bad enough, fibrosis. So typically, most cases, the virus is gone within a few weeks, but the cleanup, or the virus is gone within a few days. But the inflammation that you see, if you MRI someone in the acute setting after that, can take several weeks. So you'll see an abnormal MRI as there's basically cleanup from that with the inflammation, remodeling, fibrosis, and edema that takes place after someone's had myocarditis. Ideally, within 3 to 4 weeks, that tissue has returned to normal, but the more severe the case, the more fibrosis you'll have, and then these changes are manifested in different ways on CMR. So this is the Lake Louise criteria, which we use for diagnosing myocarditis by MRI. And so the main criteria are, the hallmark is myocardial edema. So either the abnormal T2 images, or I'll talk about a little bit about T2 weighting images. So the T2 mapping or the T2 weighted images, I'll show you in just a second, are all representative of edema, which is the hallmark of this. T1 images, you'll see this kind of non-ischemic myocardial injury. So you expect abnormal T1 fibrosis or late gadolinium enhancement on these patients. Then there are some other supporting criteria. If the patient has an effusion, that may be indicative of pericardial infusion or significant LV dysfunction. Those are kind of supportive things. But really, what we're looking for is edema and particularly late gadolinium enhancement. So edema is the hallmark of this disease, and so these are the T2 weighted images where water will show up bright. These are not the T2 mapping images, so they're weighted. They're T2 specific weighted sequences that we acquire, and so you'll see water is bright on these. And so in the myocardium here, you can compare this to the skeletal muscle out here, and you'll see that the way this looks, and then this myocardium is much brighter. There's a lot more edema there, so that's indicative of potentially of myocarditis. T2 mapping is probably preferable to these T2 weighted images. The breath holds for the patients are shorter. You can get an actual quantitative assessment with a measured number, you can use that are helpful, and it's probably better than like the T2 weighted images. So we do the T2 mapping more frequently here at Emory. Myocarditis, expect to see a lot of hyperemia. You see this after the first pass images, and so these are right after you give contrast. This is kind of the original, before we had mapping, way to look for myocarditis. And so the capillaries are very leaky, and there's a lot of flow to that inflamed myocardium, capillary blood flow to that inflamed area. So you would actually see these brightened areas when you give a contrast initially, and then it kind of goes into the myocardium. You'll see certain areas that are brightened, which will show you there's a lot of hyperemia in that area, may be indicative of myocarditis. The LGE images, so just the thing from this slide is that we'll see this kind of patchy subepicardial gadolinium enhancement with myocarditis. That's the buzzword, the hallmark that we use for this. Subendocardial is not, subendocardial is typically not involved if you're talking about just myocarditis. Typically it's just epicardial. So ischemic heart disease is the one that you'll see the subendocardial enhancement for. So that kind of tells you the differentiation between those two if you're looking at the gadolinium enhancement images. And typically we see this in the basal to mid infralateral wall is the most common area where we see this in myocarditis patients. And so this shows that, so here's the epicardium here, and you see this subepicardial enhancement on the delayed images, which is consistent with myocarditis. Cardiac amyloid basically can give you the accurate assessment of things that you see if you're looking for amyloid in MRI. You know, if your echo images, these can kind of confirm what you see with echo. You can measure your wall thickness, systolic function, looking for pericardial effusion, looking at valve morphology and thickness. It'll give you the exact measurements. You know, you can really see your endocardium well and get the true wall thickness measurements. The gadolinium images, and so when we look at these, like for instance here, you can see that this myocardium is really nulled well. It's completely black. If you have an amyloid patient, you'll have a difficult time getting this myocardium ever truly nulled because it can be global. It's hard. It can be sometimes hard on the late gadolinium enhancement. You don't like get these nice regional findings sometimes. And so if you have this kind of global involvement of amyloid, you'll see, like as opposed to this image, that you're unable to really get nulling of the myocardium, which is a hallmark of amyloid. Typically, this is the subendocardial distribution, and it's usually diffuse global subendocardium. So this shows you this here. So this is really the best image, I think, for this one. So you see this bright strip kind of all the way around the endocardium right here, which is typically what you'll see in amyloid. So this is different. You differentiate this from ischemic heart disease, and this is not in a coronary distribution. This is kind of a global distribution. And so as opposed to like myocarditis, which has the subepicardial enhancement, here you'd expect to see the subendocardial enhancement with amyloid. You can use CMR. I mean, it's not definitive, but it can kind of help a little bit differentiate AL amyloid from TTR amyloid. The T1 mapping AL amyloid will have much higher values, and it may be helpful looking at the T1 mapping specifically. If you can't give the patient gadolinium, if you have an ESRD patient, you know, with somebody with amyloid, you have oftentimes kidney dysfunction as well. So if you want to avoid the gadolinium contrast with MRI, you can use no contrast on these images and just get the T1 mapping, and that can kind of show you what the values are and be helpful to help differentiate between AL amyloid and TTR amyloid. And then you see much more gadolinium enhancement in TTR amyloid than you do AL amyloid overall. Sarcoid, so typical findings seen in sarcoidosis you would expect to see: biventricular dysfunction, dilation. Gadolinium enhancement, we say on sarcoid, what we're looking for specifically is these basal and lateral segments, particularly the septum, which it's really not a specific, you know, subendocardial, subepicardial pattern. We'll see it oftentimes at the RV insertion site sometimes, and basically it's usually subepicardial extending out, but it can be variable as well. It can be transmural, it can be subendocardial. It's hard to say. So sarcoid, the gadolinium alone is not helpful necessarily to say this is sarcoid. You have to put together kind of the patient's other clinical pictures, what their lung findings are, and put all those things together to point towards cardiac sarcoid. I was looking at similar. This is looking at the gadoliniums, I'm sorry, for a sarcoid patient. So you see kind of this basal septum segments have a lot of gadolinium enhancement, which is what we typically see. For hypertrophic cardiomyopathy, you can get really accurate assessments of Welby wall thickness, which was helpful kind of figuring out exactly where you have the most hypertrophy. If you don't have, you know, is it septal, is it apical, depending on, you know, you have the regional hypertrophy that you would have with hypertrophic cardiomyopathy. So MR can kind of tell you exactly where you're having that most at. It's helpful for also differentiating from other causes of LVH, such as athlete's heart, hypertensive heart disease, or infiltrative cardiomyopathy. So infiltrative, you'll expect to see these abnormal T1 times, gadolinium enhancement. Hypertensive heart disease and athlete's heart specifically, you won't expect to see any gadolinium enhancement or abnormal T1 mapping. It's helpful for the assessment of the LVOT obstruction, and then usually in the areas that you have hypertrophy. On a hypertrophic cardiomyopathy patient, you'll see that there's some gadolinium enhancement, there's some fibrosis there, which will light up on the gadolinium images to show you, to kind of help differentiate what you're dealing with and show you exactly where there is some scar there. Due to time, I'm going to skip this, but basically this shows that LG is helpful, the gadolinium is helpful for prognosticating sudden cardiac death in patients with hypertrophic cardiomyopathy. So sometimes we'll use that if somebody's questionable about whether they need an ICD or not. We get an MRI and they have a ton of gadolinium enhancement and scar there, then there's someone that has worsened outcomes and has a much higher risk of sudden cardiac death. So a lot of times that'll push them forward to getting an ICD. ARVC, MRI is helpful for this just because you can really see the RV so well on MRI as opposed to echo. Sometimes it's difficult to get the total views of the right ventricle. So you assess for warriors or wall motion. The criteria that we have for assessing ARVC, you're looking for these kind of regional wall motions, and what you see typically is this basal RV right here, this kind of accordion type pattern. So as this is diastole, this is systole, and you can kind of see how it pooches in like that, and that's the accordion pattern of wall motion abnormality that you would see on echo. I'm sorry, on MRI. Gadolinium can be difficult to assess in these patients just due to how thin the RV wall can be, but oftentimes you'll see this kind of diffuse gadolinium enhancement here, which is indicative of abnormal myocardium and maybe indicative of ARVC. You can also do fat saturation images where you're looking for where fat will light up on MRI, which is the hallmark of ARVC, is that replacement of the myocardium with fatty tissue. So you can do fat saturation images as well as if you're looking specifically for ARVC. Non-compaction cardiomyopathy, MRI is really good looking for thrombus specifically. So you can see if you have, you can also look at the morphology of your myocardium here and you can see all this non-compacted myocardium. You can actually go through and quantify the ratio of non-compacted LV mass to normal myocardium. You can calculate your LV mass that's compacted versus not, and a ratio of 2.3 to 1 for the non-compacted myocardium is diagnostic. And so we use that if we're looking for LV non-compaction. If it's not clear on echo, we can use MRI and calculate this ratio and kind of confirm this diagnosis of non-compaction. Okay, we have 10 minutes left. So I'm going to talk a little bit about valvular disease. Just off the top, a lot of assessment of valvular disease with CMR is very similar for each of the 4 valves as far as the things that you can calculate and what you're looking for. So I'm going to go through these probably kind of quickly, just because it really gets repetitive as far as it's also a valuable tool for valvular disease, but it's very similar for each of the valves. So the Cine images, you get really good, clear visualization of all 4 valves, specifically looking at the valve anatomy, especially the right-sided valves, which may be difficult to visualize on echo. You have, essentially unlimited planes that you can use to cut through different slices to obtain MRI images if you're looking at something specifically on the valves. This also can give you accurate and reproducible measurements of function and volume. Specifically, if you're following a lesion serially over time, you can use MRI to really give you accurate assessments of what the volumes are over time and when your LV is starting to dilate, and once you get certain cutoffs to help guide therapy as far as valve replacement. You can use the flow quantification, the flow that we talked about earlier, to tell you your exact regurgitant volumes of blood that's regurgitating through each lesion, or a peak velocity if you have stenosis there. You can also get ideas about the jet size, the location, and how intense the jet is. So aortic stenosis, echo is really probably the gold standard for that as compared to MRI. There are some things you can get from MRI. You can really do valve planimetry is probably the best assessment of the actual aortic valve. how stenosis the valve is. You can do these really thin cuts through the valve to kind of identify what the exact orifice is. And then these measurements that you get, they really correlate well with TE and continuity equation measurements of the aortic valve. You get the true planimetry of the aortic valve. This is helpful also for supravalvular and subvalvular stenosis, using that velocity mapping we showed about earlier, where you see areas of increased flow velocity to figure out exactly where you're having increased flow. So it can help you if you don't have true valvular stenosis, and which can be difficult to pick up outside of echo sometimes, or on echo sometimes. You can use MRI to kind of use these in-plane measurements to tell you where the exact flow is, and be helpful to identify non-valvular stenosis. So this is an MRI. So this is a nice picture. You can really tell exactly where the leaflet tips are, and do planimetry of the valve there to kind of see what the actual area is. And so you just have to make sure you're actually at where the tips of the valve are, and then get this measurement, and you can measure here. This is showing an aortic stenosis, kind of where the highest velocity is. These little black pixels here show you that your velocity there is higher than your bank times. This is the highest velocity area, and you can kind of tell exactly where that is. AI, so CMR is really valuable in AI specifically, just because you're able to calculate the exact regurgitant fraction in your LV volumes. So we use the flow mapping. You have to make sure that you're just above the aortic valve tips where you measure the flow, and you can cross that check that with your stroke volume as well. And so basically, you get the measurement, and it'll tell you what the forward flow was in that area where that slice where you do, and also what the reverse flow is. So then you can use that, the forward flow over and use that to show what your percentage, your regurgitant fraction is. So if you have, whatever, 100 ml forward flow and 30 flow back, and you have 30% regurgitant fraction, you can use that MRI to tell you that exact measurement. Once you get above 33% or so regurgitant fraction, that's been shown that those patients eventually will need valve replacement. So this shows kind of the cut right through the aortic valve right here and here's the aortic valve, and this is where you would want to measure your flow. And then also you can get an idea on the stent images. A lot of times you can see the jet with AI and show you kind of how exactly big your jet is and where it's directed, which is helpful. Let's skip that. MR, similar to AI, you can use it to calculate regurgitant fraction. TE is probably still better for MR specifically, but if there are some patients who can't get TE, and you're trying, or if you have a borderline, really eccentric jet on TE that you have a difficult time kind of quantifying, or patients on the borderline, you want to measure their volumes and see how severe the TR is. I mean, how severe the MR is. MR is helpful. Planimetry is not useful as much, just given the complex structure of the mitral valve. It's not really for calculating like your ERO. MRI is not that helpful. You are able to kind of slice exactly through each coaptation of the mitral valve to identify, where your lesions are, which I'll show you in just a second. And then you can use regurgitant fraction here. So you take your stroke volume that you calculate with your LV, and then you subtract your aortic flow, and that tells you, what percent of that, what the actual mLs are that are going back, and it can give you your kind of regurgitant fraction. If you have regurgitant fraction over 40% on CMR, that's a good predictor for needing future valve surgery. So here, this just shows that you can make a cut through each. This is a short axis view of the mitral valve, and you can actually take a cut through each section of the valve and kind of show the specific coaptations. So here, you see here's your A3P3, your A1P1 coaptation. Here at A2P2, you can see that this prolapses back and kind of tell you exactly where your lesion is on your mitral valve. So I'll talk just briefly about pulmonic, and then we'll probably be done. So CMR is the gold standard for assessment of the pulmonic valve due to the difficulty with visualization on echo. Pulmonic stenosis you measure similar to AS on MRI. You're able to kind of get the planimetry of the valve, measure the valve function qualitatively, just because you can see it well, you can see how well it opens, and you can get your peak velocities there. PI, this is very helpful for assessment of PI. You can basically measure your regurgitant fraction with this, and you can also get the RV volumes, which are the big things which drive the need for replacement of your pulmonic valve, especially, in these patients that have repaired TETs. A lot of times they'll have pulmonic insufficiency. And so you follow them serially over time, follow their RV dilation and volumes very closely, and you can kind of tell small changes in that and when the patient is going to need their valve replaced. If you have a regurgitant fraction of greater than 40%, that's considered severe in pulmonic insufficiency. This is a pulmonic stenosis. This is the RVOT and pulmonic valve here. And so you see this flow acceleration here through the pulmonic valve, which is indicative of stenosis there. This is also looking at PI here. And so you can use your in-plane flow measurements here. And so you can see there's this huge regurgitant jet back through the pulmonic valve. Tricuspid valve, I'm not going to talk a whole lot about, but you do need to probably do, we can see a lot of times on cine images of the LV because of the high pressures and a higher flow through here. You'll see, like on MR, you'll see a regurgitant jet on cine images. But a lot of times you won't see that much on TR just because of the low shear and lower pressures through the right side of the ventricle. But here, like you don't really see a jet at all on cine images. But then when you get these flow mapping through here, you see this huge regurgitant jet, and look how big this is through here. And so this is really severe TR. So you need that if you're looking specifically for TR in these cases to make sure you get your flows, in-plane flows in that. Cardiac masses. So I'm not going to talk a ton about this. In patients with LV thrombus, if you have an echo, it's unclear. You get the contrast on the echo, and you can't still totally tell exactly what you're dealing with. MRI is excellent at identifying LV thrombus, and so on these gadolinium images, you can see, there's not any flow or any enhancement in the thrombus. And so this is a nice image because you can see they had their big infarct right here, right? This is all lit up here, all enhances with a nice kind of hinge point there. And then you can see this thrombus right here, which is totally black, and here as well. So LV thrombus is really apparent. You can do like a TI time of 600 and really null everything out. You do a delayed TI time, so after you give the gadolinium, so you wait even longer after that. And you see how now everything is you're giving a lot of time for the gadolinium to wash out and enhance kind of everywhere else in the or be taken up by the myocardium. And then here you see this just nice black structure, which is the thrombus there. Specific for tumors, depending on kind of where they are, that would be indicative of what you would expect to see there. These are all the things that you can pick up oftentimes on MRI. So MRI is helpful for looking at cardiac masses. And then I'm not going to talk a lot about congenital, but CMR is vital in congenital heart disease just because the complexity of the patient's anatomy is really good for identifying exactly what they've had done and what their exact anatomy is, and then for following them serially looking at ventricular volumes and valvular disease, knowing kind of exactly where and when things need to be replaced. You can also evaluate your Fontans and your shunts with this. So this is a CMR. You see the IVC here, and you see the Fontan plug into the PA here. And so you can assess your Fontan size. You can do flow. You can do all kinds of things. And you can do flows through the Fontan to make sure that your flows here are similar to your LV flows, and make sure you compare your Fontan flow to your PA flow. And you can get lots of different flow measurements and size measurements in congenital heart disease. So CMR is a huge, huge part of following these patients. Okay, and that's it. It's 8:30.
The preceding program is copyrighted by Emory University.